So welcome back to another edition of the Heart to Heart podcast. And my guest today is Dr. Wes Ely. He's the author of Every Deep Drawn Breath and an ICU physician at Vanderbilt University. So welcome to the show.
Thank you so much, Michael. I appreciate you.
Well, I certainly appreciate you coming on because just like we were talking about, before the show, like it seems like unfortunately a lot of people who are, really anti-vax are really able to voice their opinion and certainly want to voice their opinion. And I think that a lot of people with a more balanced approach or who are, trying to, utilize vaccines in this disease are sort of, not always getting their voice heard. So, it's just really great to have you on the show. So thank you so much again for coming on.
You're welcome. And I want to say that, I'm kind of a middle of the road person in life generally. So I don't really live on either extreme of things. Maybe earlier in my life, I was a little bit kind of crazy as a college student. But right now, I kind of live in the middle. And I still think, even with my middle of the road stance, that the data are just so great to help us. I'll be so thankful to have these tools to help reduce the spread of such a deadly problem,
Yeah, absolutely. I think that, you kind of hit it nail on the head when you said data. And I think that, we need to be making, data-driven decisions. We need to make data-driven decisions always, but, certainly for COVID-19. And where do you think maybe that, we haven't made some data-driven decisions, and where do you think we have been effective in making those decisions? So I know that's certainly a long conversation. I don't expect you to answer it in 30 seconds, but, off the top of your head, where do you think we're kind of going right, and where do you think we're kind of going wrong right now?
One of the beautiful things that's happening is that our data from large placebo-controlled randomized controlled trials are showing us that we now actually have medical therapy to treat people early in the disease before they develop profound illness, drugs like Paxlovid and Mulpinovir, and some of the monoclonals, of course, which reduce hospitalization. And that if you then do still get severely ill, we have some great data to say how to handle people when they're profoundly ill. And I actually designed the randomized controlled trial. You probably don't even know this, but I designed a randomized controlled trial of baricitinib. We call it Bari, like Berry, Bari, but it's baricitinib. It's a JAK inhibitor, which has the largest mortality reduction in any drug in COVID. We can come back to that a little later. It's got a very cool story because the computers predicted that would be a great drug for COVID, and then we went and proved it. So we've got data at the early stage of the disease, we got data later in the disease, and we have a lot of preventive data with regard to how do you stop somebody from getting infected in the first place, specifically, of course, millions and millions of people having been vaccinated, and now data in younger people as well. And then, of course, pretty amazing data on masks and how even unilateral masking, so your mask's now not, you protect yourself. So right. You don't have to depend on everybody else to have a mask. If you have a KN95 on and are vaccinated, that's about as good as it gets right now in terms of protection, and the data on that are really solid.
Yeah, that's kind of the way I've seen it too. And I listened to a discussion recently with Dr. Peter Attia, Marty, I forget, Passad, I think of his name, I forget, and a couple other physicians, and Monica Gandhi, I think, was on there too, and she's been fairly pro-vax, pro-mandate kind of physician, but she said too, like, one-way masking right now seems to be sufficient, and she did say that the data is pretty clear that N95, KN95, she mentioned a couple other more. I'm mostly familiar with the N95, are much more efficacious than some of the other masks. I think there was a study that they were talking about where when they were around someone infected, if they had an N95 mask on, their chances of actually getting infected was like close to 0%. Whereas if they were just wearing like a cloth mask, it was still around like 10%. I think with the surgical mask, I was fairly surprised. I think it was still like 4.5% or something like that. So they do tend to, definitely reduce transmission, but it's infection, but it definitely does depend on the quality of the mask that we have.
Sure, absolutely. I would agree with that. And the surgical mask being kind of in between the cloth and the KN95.
Yeah, yeah. So that's sort of, I guess, the simplest way to say it. She got into about, I don't know, 6 or 7 other different masks that kind of seem to like overcomplicate the conversation. So, the ones that people are most familiar with are, again, the N95 or something similar to that, the surgical mask, and then the cloth mask. And by far, the best mask wear would be the N95. And again, it's okay. Like they were saying in that podcast, and I agree with them that mask mandates are not really necessary, but it doesn't mean that masks aren't useful. It just means that you wear the mask when you're trying to protect yourself. And some people are going to be very, very vulnerable. They're going to be people who have immunocompromised conditions, and for those people, they should absolutely be wearing the best mask that they have. Now, if you're someone who's healthy, double vaccinated, you probably don't need to be wearing, masks in public. Like, I'm not sure what your stance is on that overall.
I think that humanism is something that we all want to get to. In this conversation today, we'll talk a lot about humanism, meaning how do we get back to being the people that we want to be and be caring and loving towards each other. And I think that we need to see each other smile, so when we're out in the public, and it does us a world of good to see somebody smile and laugh. And if you're vaccinated and walking around distance from people, then I don't wear a mask in that circumstance. I think that I want to see, like, it's great to see your smile right now. And, you got a great beard going there. And this is what makes us human, is seeing each other's eyes and our mouth and everything. But when I'm in close spaces, I'm respectful of other people, and I do wear a mask. In my book, Every Deep Drawn Breath, I am really focusing on the power of human story and letting people's stories drive us to become better human beings and to care more for one another. And that's really my shtick in medicine, is that for many, many years in medicine, I think I carried around a lot of shame and guilt because I was not doing a good enough job of really seeing the other person, meeting them where they are. And what I've learned is that I really want to kneel down and hold your hand and look in my patient's eyes and then meet them where they are. And that does mean that I approach people who come in the hospital, anti-vaxxers who haven't been vaccinated and now have COVID, with as much love as I can possibly muster, and say, hey, I'm a person just like you, and I've made really, good and very bad decisions in my life as well. But I'm here to serve you. I'm here to protect you and provide good medical care for you and to help you get through this. And regardless of what it brought them to make those decisions, which a lot of times is somebody else telling them bad information. I want to be a great doctor for that person and show them love and respect and kindness.
That's so nice to hear, because we do hear some stories of some physicians unfortunately not treating some patients very well when they're unvaccinated. And again, this, I've stated so many times in my podcast, on my social media platform, that I do feel that the vaccine is a very, very effective tool for reducing severe disease. But I'm certainly not going to shame anybody or make them feel any worse, because a lot of these people, if they have acquired COVID, I mean, they already have something bad to deal with. And so adding anything on top of that is not my place to do, and is not beneficial in any way, shape, or form. So it's great to hear that that there are compassionate physicians out there for the unvaccinated. And sometimes it's not all the time. It's probably fairly rare, but there are some people who are unvaccinated who probably do have some medical conditions that may not warrant them being unvaccinated, but it may certainly scare them into being vaccinated. And some people may have just had a really bad experience with a vaccine in the past. And like, for myself, I've never had a bad reaction to a vaccine. I've never had a bad reaction to a drug. So taking the vaccine for me wasn't that like scary because I didn't have that history. But some people are going to have a history of getting a flu shot and then having to take weeks off work because they got a migraine or something strange, or Guillain-Barré, or something fairly rare. But you do have to understand why certain people are making that decision, even though overall it does seem to be an incredibly efficacious and safe tool overall. But given that we just said that, do you feel like there's any category of people right now that probably shouldn't be vaccinated, or do you feel that everyone should at least be double vaccinated, and if you're immunocompromised or above the age of 50, you should definitely be boosted as well?
I think that the data are so solid in terms of the safety of these vaccines. The mRNA vaccines have the most data, that it's almost as safe as water. And there are people who get myocarditis, but the risk of that is extraordinarily rare. And even when it does happen, it's usually mild and recoverable. So the circumstances in which somebody has a legitimate reason not to get vaccinated from a medical perspective are vanishingly small. Let's put it that way. And that does not, though, supersede the idea that between a patient and their physician, that they can make an individual decision in those circumstances. Now, this week I got an email from a friend of mine who said that their daughter was in nursing school and that the daughter had asthma, and that their doctor had advised them not to get the vaccine. That makes no sense. There have been very, very few and far between, again, vanishingly rare episodes of bronchospasm in and around the vaccine, but this person isn't experiencing active asthma. They have a history of it. And so they should be protected as much as possible, especially if they're a healthcare provider, a nurse at the bedside with patients. You as a patient don't want somebody breathing on you who is shedding the virus. So I think that's probably my answer to your question.
Okay, so you don't believe, say, for like males between 16 to 24, that there's a higher incidence, say, of like myocarditis from the vaccine itself than from COVID?
There is the reports in the New England Journal do show elevated risk, but these are very, very rare, and the risk of the COVID and or of long COVID after the viral infection abates acutely, and then 100 days later people get long COVID, to me are way more common than the risk of the myocarditis issues from the vaccine. So, if you throw in that even as low as 10% of people get long COVID, and in some reports is as high as a third, even if you go down to half of the 10 and you go down to 5%, that's still way, way more common of a problem than the myocarditis in terms of the numbers there. So again, I think that if it happens, it's very unlucky, and I don't wish it upon anyone. But if you actually are just going to play the numbers, then you'll get a greater benefit from the vaccine than you will pose a risk to yourself.
Okay, so even in that age category, like male 16 to 24, you would feel that they would have a higher chance of getting myocarditis from COVID than from the vaccine itself. Is that correct?
That is correct. And much higher risk of other complications and of just getting COVID than from any side effect of the vaccine. So I would recommend, unless there's some specific reason, some specific conversation between a young male and their physician to warrant this, that these are people who will benefit from the vaccination.
Okay. And then same too for, say, children 12 years and younger, like you feel that they would also benefit from getting the vaccine as well?
They do. Now, there are the original Pfizer studies. Of course, they're going back to use a higher dose and a third dose even. So we still have more data emerging coming out from that. There's no doubt that we are earlier in our data for the children, and especially in the children less than 5. But I think on weight that the data are in favor of vaccination in all of those who have already been approved. And you asked earlier about boosters, and I would absolutely say that 3 to 6 months after you've received your second dose, that we know that the immunity wanes, and it's time at that point to get people boosted. Unfortunately, in the United States, only 23% of people are boosted. which is just crazy to me because there's so many people who could benefit from getting boosted. And now we have data coming out from Israel, even of the fourth shot. So I think that people are saying, oh gosh, I'm so tired, we're going to get a fourth shot and a fifth shot. Well, yeah, I mean, this is going to be an endemic problem for us now. This virus will be a part of our life now for many, many years to come. And we need to get it in our mindset that it is the right thing to do, the charitable and the loving thing to do, both for yourself and for others, to be up to date on your shot. So we're not going to call this a booster as much as we're going to say just whatever the latest up to date rules are from a data-driven perspective. Are you up to date?
Okay. So you do feel then that, people are going to need to get this shot every 3 to 6 months, so to speak, because it does look like the antibodies do seem to decline, fairly rapidly after about 10 weeks or so. So, I mean, in that case, people would really have to be getting shots, multiple times per year. But so do you feel that is the best and necessary course of action that we should take?
I think it's too early to say that. I think we don't know the data on that just yet. What I would feel comfortable saying, though, is that we will, over time, end up needing more than just 2 shots. And I've already had my booster shot, my 3rd shot, and I think that over time in my own body, I will not have adequate protection that I would consider sufficient to protect both me and my patients from me shedding on them. So what the frequency is, I don't want to say that because it's too early to know that. But I think what I'm saying is that I think we just need to get in the mindset that if we are going to be kind of one for all for one as society, that we need to be ready for the notion that the original couple of vaccine shots that we received won't cut it down the long term. And I was joking with somebody yesterday, free virus now. All pathogens have rights too. We should let this virus go crazy. I was being facetious. We shouldn't. We should not let this virus just run rampant through society. We should try to shut it down. And remember that when the virus enters a body and sits there for a while, that's when it makes itself into a mutant variant and then allows over time for us to get more dangerous circumstances like we did with Delta and Omicron. So we would prefer that people just shut down the overall transmission and primary infections if we can. And I think that's going to take multiple shots.
Okay. And do you feel that we should be utilizing natural immunity when making these decisions? Like, do you feel that if someone has had COVID and recovered, that maybe they would need less protection, less vaccinations at some point?
I don't think that well, first of all, it's interesting you use the term natural immunity, and I want to point out the fact that our response to a vaccine shot is a natural response. That's what our body evolutionarily did over time, was said, when we get exposed to something like this, we are going to naturally mount an antibody response. So our protection from the vaccine is a natural recourse, evolutionarily determined, of our body to that vaccine. But I know what you meant earlier was just an organic acquisition of COVID, building up some antibody response to that. Is that okay? I don't think we have, the data are very clear that you cannot tell whether or not you mounted a good enough response to obviate the need for a vaccine. Put another way, if I get COVID tomorrow, and it's already been time for me to get a 4th shot. Let's just say that the FDA approved a 4th shot for somebody like me. I'm 57, and I got COVID. I would still get the shot because I do not know that COVID infection mounts the same sort of robust response that the vaccine would give me. So I'm not going to depend on that natural COVID infection. I'm going to let my body do what it can after getting a vaccine, so I can. That's a much better way to regulate this from a societal perspective.
Okay. So even if you were, say, double vaccinated and then you got COVID, like, you wouldn't count that as, say, like, your booster shot. You wouldn't.
Absolutely would not. I would wait a little bit after the COVID. We don't know exactly how long, but I would get over the acute illness. And if it was time for me to get my booster, I'd go get the booster.
Okay. Okay. Understood. And I do want to chat with you specifically about a couple of medicines, particularly the Paxlovid, just because that's one that's excited me the most, or seems to have the best data. But although you mentioned another drug earlier, so we'll chat about that too. But do you feel that the efficacy and safety of these drugs are so good that eventually we'll be able to maybe vaccinate people less, or do you feel that the best strategy is to keep vaccinating and then also to utilize these drugs as early treatment?
Imagine that you have a little river. I haven't been asked this question. I've never given this analogy before, so you might think I've got this prepared, but I don't. This has occurred to me as you were talking. Imagine a river with a waterfall at the end, okay? And way upstream from the river is a calm bay of water that's not flowing. And then 50 yards down from that is the beginning of the rapids. And 50 yards down from that is the waterfall, okay? So think of it like this. The waterfall is full-blown COVID. Sick person. They're getting baricitinib, they're getting steroids, okay? 50 yards upstream from that, where the rapids are developing, is acute COVID, but not hospitalized. That's where we want to be treating people with drugs like Paxlovid or Mulpinovir or a monoclonal. And then 50 yards up from that is the calm water before the rapids even start, which is your area, your best place for prevention, okay? So the best place for society to put most of our efforts is all the way upstream in the calm water with vaccinations and masking and social distancing. That will prevent people from ever even getting the infection in the first place the best. If they do get it, however, and they get down to that halfway point where the disease is occurring but not hospitalization, then we are so lucky to have data from placebo-controlled trials to say that either Paxlovid or Molnupiravir help prevent the progression of disease, help prevent hospitalization, as well as some good monoclonal approaches. And then if none of that works and you come to me in the ICU and I'm your ICU doctor, I'm going to put you on oxygen, baricitinib, which is a JAK inhibitor, and steroids, as well as probably if you're on the wards, anticoagulation of some sort and DVT prophylaxis, because COVID is a vascular disease, which creates a tripling of the likelihood of you developing deep venous thromboses and pulmonary emboli. So we want to care for that part of the disease as well. So does that help?
Yeah, no, definitely helps a lot. That clears up a lot. And I'm glad too that you mentioned it too about being a vascular disease. I know there was, a very controversial podcast with Dr. Sanjay Gupta and Joe Rogan, but I remember that one thing that did come up that they both, more or less seem to agree on, was that it is, just as much of a vascular disease as it is a respiratory disease. So it's very interesting for you to say that, just because I've heard a couple other people say it. Like I said, the first time was when I heard Dr. Gupta say it on Joe Rogan, but I haven't heard too many other physicians kind of use that term yet. But there's so many things that I want to ask you, and you seem to be a wealth of knowledge on all of them. But one thing that I really want to ask you about is the early treatment in drugs, just because not too many people have sort of the clinical experience to go along with it. Like, there's a lot of doctors like myself who are just family doctors out in the community, but I'm not in the hospital treating COVID patients.
Sure, but before we get to that, let me interject a story, because if I interject a story, it'll frame why somebody might want to not get to that point. And I think that we're going to go back to the drugs. So from every deep drawn breath, from EDDB, let's see if we can get this where my face is.
Yeah.
There it is.
Perfect.
Yeah, nice. Every deep drawn breath. That's from Steinbeck's East of Eden. But I've got this story here about a patient of mine who was in the ICU. Now, let me just read you a couple of paragraphs.
Yeah, that'd be great.
During the COVID-19 pandemic, Ray Fugit sat lopsided, legs askew in his bedside chair. His secretion-streaked breathing tube sticking a few inches out of his mouth and connected to the ventilator on his left whizzed 380 milliliter breaths into him, 18 to 24 times a minute, just the right calibration. Sunshine flooded through the large window and highlighted his short reddish-brown hair, which stood straight up in the back, giving him a boyish appearance. He waved a small whiteboard at me, looking frustrated. This was the way we communicated with him. And I could see the big red words he'd written in marker: let me go see Shelley, his wife of 30 years. He had been in the ICU for 2 weeks while the coronavirus destroyed the lining of his 51-year-old lungs. On rounds that morning, I heard the familiar snap, crackle, and pop of Rice Krispies across the front and back of his chest. He was struggling with deadly COVID pneumonia. Now Ray was writing all over the whiteboard, and when he held it up again, the words didn't make any sense. It was just a scribble of red ink. As much as his lungs were burdened by disease, his brain had it even worse. He had delirium. It was a devastating presence with this virus, and an ICU stay exacerbated the effects, especially when we couldn't have family visit at the bedside. Ray needed Shelley, and Shelley needed Ray. One more paragraph. The next day, his delirium lifted, and he was improving enough for us to remove the ventilator and try less aggressive ways of delivering oxygen. This also meant that he and Shelley could talk on the phone. Unfortunately, as he spoke, he spiraled down into delirium again, and his oxygen levels dropped. I heard him yelling, Shelley, come and get me now. They're trying to kill me. Shelley, they won't leave me alone. They're holding me against my will, Shelley. I have to get out of here. And it was really hard to see Ray go through all that and to hear him screaming for Shelley. But the reason I wanted to read that story is that when COVID gets in our body, it does all destroy the lining of the lung, but it also messes with the lining of our blood vessels. And as I said earlier, it's a vascular disease. So what was happening with Ray was that his brain was not getting the oxygen and food that it needed. And so his neurons were basically, gasping for air and nutrition. And then they were going awry and he was getting delirium. So delirium in COVID is a profound problem. And we studied over 2,000 COVID patients at the beginning of the pandemic and found that 80 to 90% of people were getting delirious once they were in the hospital. So what we have to do, and what I want your listeners to know, is that our goal here is to prevent the disease from occurring, but if it does still occur, give them these drugs you're about to ask me about so that they won't progress. And if we have a safe drug to give to prevent them from ever getting to the point where Ray was, then that's the way to go. So that's your backdrop. That's your clinical story. That's what we're trying to stop from happening. And now let's get into these medications and how to prevent the development of what occurred with Ray.
Okay, let's definitely do that. And I definitely want to ask you too about long COVID after.
Sure.
Yeah. So again, the one that excited me the most was the Paxlovid, and the reason why, I mentioned this, I think before the show started, was in the study, it showed to be incredibly efficacious, like reduced hospitalizations, I think by close to 90%. And then in the treatment group, they actually had less adverse events and less people discontinued the drug than the placebo group, which shows that it's incredibly efficacious. So, are you, very excited about this drug, and do you think that, it can be as good clinically as it was in that one study?
Paxlovid is a combination drug of two agents. It is in the data we have thus far. It is, as you said, highly efficacious at preventing progression of disease and hospitalization. And the safety profile is pretty profound. I mean, there were more adverse events in those people getting sugar tablets than there were in the Paxlovid. The problem with Paxlovid is not the drug itself or its safety profile. It's that it's a complicated drug to make, and the company hasn't made enough to make it widely available. So if it was widely available right now, I think it would be prescribed like candy for people who have COVID and don't want to see themselves progress. I have no financial conflicts of interest with this drug. I'm not working for that company. I have no stock in this drug. I was not involved in the investigations. I want to make sure that that's very clear to your listeners. But I do think the drug is going to be a good one for COVID once it's produced enough that we can have it readily available. But right now, for example, my patients can't get to it. The Mulpinovir is another drug that doesn't look as good as Paxlovid, but it still is good at preventing. It's kind of a kissing cousin in terms of what its goal is. Its goal is to prevent progression of disease. Its safety profile is good, but not as great as Paxlovid. So those are two, let's say, drugs in our armamentarium to use to prevent progression. That plus, depending on what your local monoclonal antibody availability is, that's really what to do to try and get yourself from progression of disease if you get COVID and you're high risk to. Oh, by the way, they were studied in people who were high risk to progress. So those drugs were not studied just in a completely healthy population that had no risk factors for progression. So that's
which makes it even more impressive.
Yeah, even more impressive because they were likely to progress, but they didn't. So those are my thoughts on that. Let me tell you the baricitinib story. It's very interesting. And I have no conflicts of interest with Barry either, but this is pretty cool. So,
just one question on that. Sorry, before you go on. Does that cover all the variants, the Paxlovid? Like, would that be good, say, even against Omicron? Because my understanding, not to sidetrack things too much, is that the monoclonal antibodies were very effective against the Delta variant, but not so much against Omicron. So just warning about Paxlovid.
Yeah, we need data on that. The data from the Paxlovid trials were pre-Omicron. So we need more data on it, but it looks like that from a mechanistic perspective, we expect it to work well against Omicron as well.
Okay.
So that is absolutely expected to be good because we know what morphed in the Omicron, and the way that the drug works is not what changed with Omicron. So it should still be efficacious.
Okay, excellent. Thanks so much for answering that. Appreciate it.
Okay, go ahead. So we haven't brought this up yet. So let's cover this. The big problem with COVID is not necessarily the virus itself, but what the virus causes the body to do to the body. So when you get the virus, the body starts to create an inflammatory storm, which then causes further destruction. And that's been true of sepsis. We've known that for years. 25 years ago, we had the only FDA-approved drug for severe sepsis, which was called Rocagen alpha. It was activated protein C. And what we were trying to do there was shut down the body's response to bacterial sepsis. Well, similarly, in COVID, we want to shut down the body's response to the virus, and that means shutting down inflammation. So for 10 years, a pattern of inflammation that's present in HIV, AIDS, has been recognized and tested to fight against it with drugs called JAK inhibitors, Janus kinase inhibitors, JAK inhibitors. And one of the JAK inhibitors is baricitinib. So early in the pandemic, in March of 2020, a guy named Justin in London studied with a large computer database, studied all of the hundreds of drugs that he thought that could potentially repurpose for COVID. And the computer analysis of these gargantuan amounts of data said, of all the drugs that we think you could repurpose, the one drug we think will work the best against COVID is baricitinib. So based on that study, Justin Steving's study published in Lancet, I and a guy named Vince Marconi from Emory University, he's an infectious disease doctor, who was aware of this 10 years of study of JAK inhibitors in HIV, designed a clinical trial, placebo-controlled randomized trial with 1,500 patients, and proved and published it in Lancet Respiratory that it was that overall of all comers in the hospital, we had a 5% reduction in death as compared to placebo. If you were already on high flow oxygen or face mask, you had an even bigger percentage improvement in the like in the neighborhood of 15% of survival, reduction in death. And if you were already on a ventilator, we did a subsequent study just published last week in Lancet Respiratory that showed that the benefit was approaching 30%. So one way I like to express that is number needed to treat. And it's very cool. I love it when we get consistency of message in science. So the summary is, if you are in a hospital and on oxygen, treatment with baricitinib, which is a PO drug, just one pill a day for 14 days, one additional life save for every 20 people treated. If you're on BiPAP or high flow, one additional life save for every 9 people treated. And if you're on a ventilator, one additional life save for every 6 people treated. And the last part of the story is that we made Eli Lilly, the company. I have no stock in Lilly, and I didn't receive a penny to do this study. I made sure I didn't receive anything because I didn't want to have any financial conflicts. we made them agree to provide the drug free all over the world to any lower middle income country so that people all over the world could receive the drug without having to pay if it worked. And it did work. And right now, any doctor who hears your podcast in any country can work with their Ministry of Health to get the drug free for their patients.
That's amazing. That's amazing clinical work and very good data too. I mean, that's a lot of lives could be saved with that drug. So, thank you so much for doing all the work, and thank you so much for making that available for people, because as we know, people are struggling to treat their patients with this with any type of medicine right now, and particularly if something like Paxlovid is just not really available. The fact that this is available and can in fact reduce deaths is incredible. So,
and by the way, the safety profile was equal to placebo. There were no safety adverse events, even in immunocompromised patients, and et cetera. So that's pretty cool. And by the way, all this idea of the humanism that I was talking about earlier, and the idea that we can get these drugs free to the lower middle income countries, that's part of what we all need to do for each other. This book that I wrote, Every Deep Drawn Breath, I call it EDDB, Every Deep Drawn Breath, EDDB. Every penny from the net proceeds of this book are going into an endowment for COVID survivors and their families. And what we're finding is that people who have less of a voice in society, maybe they're people of color, they have lower socioeconomic means, less education, they are silenced and they're being disproportionately disadvantaged from COVID. And so they lose their jobs, they lose their gas money, they can't pay their electric bill, they can't apply for disability. So what we're doing with the money from EDDB is we're hiring social workers through our research center at Vanderbilt. And our center is called the CIBS Center, CIBS, which stands for Critical Illness, Brain Dysfunction, and Survivorship, CIBS. And the website is icudelirium.org. So if you just Google ICU Delirium, you'll find us, icudelirium.org. We are hiring social workers and providing free support groups for COVID patients, spouses, and families. Every week, we have these free support groups to help people pick up the pieces of their life, find their way forward, get healing, get brain rehabilitation, get body rehabilitation, apply for disability, and really just find a way forward after this terrible thing that's happened to them, especially in long COVID. And we have tons of long COVID support groups too, because long COVID is really the new public health disaster in society. And maybe you want to talk about that a little now.
Yeah, sure. So, one thing I want to talk about long COVID with in particular, because I just heard this recently, is that if you have long COVID, and I heard, it was Dr. Peter Attia who mentioned this, that vaccination can actually be some type of potential treatment for it, or at least there's some ongoing studies looking at it. So if you have long COVID, actually getting vaccinated even after, which sort of in some ways sounds a little bit counterintuitive, may in fact help the disease. I'm not sure if you read the same study or have any thoughts on that.
There are absolutely data coming out to indicate that it may help people who haven't been vaccinated to get subsequently vaccinated. We prefer it, of course, if you get vaccinated on the front end and don't get COVID. But what happens with COVID is, I want people to know about PICS and long COVID. So PICS is post-intensive care syndrome, and long COVID is separate from that, but there's a lot of overlap. If you come in my ICU and I care for you, you have about a 60 to 70% chance of leaving with post-intensive care syndrome. And what that is an acquired dementia, acquired post-traumatic stress disorder and depression, and then muscle and nerve disease. So that guy, Ray Fugit, I described to you earlier, he had really bad PICS on the back end. But in addition to that, 100 days later, up to a third of people get long COVID, which is a separate problem, which is some sort of a reordering of the immune system and the autonomic nervous system, which leaves you with brain fog and a racing heart, postural orthostatic tachycardia syndrome, or POTS, and all kinds of GI and other kinds of problems. And that long COVID problem, we think probably can be reduced by vaccination. Even if the data don't play out on that though, remember I said earlier, don't trick yourself into thinking that getting COVID is a reason to not get a vaccine. It's not, because you don't know that you're going to build up enough immunity that you would not need the vaccine. So go ahead and get the vaccine anyway. And if it helps you prevent long COVID, then that's a beautiful secondary benefit.
Okay. And then in terms of long COVID, like what symptoms are you most worried about people getting? Like what ones are people, what are the worst ones and what are the most common ones? And hopefully it's not, the common ones aren't the same as the worst ones.
Yeah. The most dangerous things that happen in long COVID that really cause disability for people are the neck up problem of the brain fog. There's something going on in the patient's brains, and we're collecting brains as part of our research project right now from COVID people who end up dying. So we have a $20 million NIH research project called Brain 2, which is collecting brains of COVID and non-COVID survivors to compare the two. But it'll be some years before we get all the results of that. But there's something happening in the brain which prevents neurons from firing and from people being able to have good executive function and memory. The main two areas of neurocognitive dysfunction are executive dysfunction and memory. So you can't organize yourself, you can't do your job, you can't turn your computer on or work well with that. You forget names. There's a lot of disabled people right now who are unemployed because they can't do the job they were trained to do. It's very, very sad. And then the other disabling thing that people get is this POTS I talked about earlier, POTS, where their heart races up and down, they get dizzy up and down, and they have all kinds of cardiovascular abnormalities that prevent them from sleeping and ambulating well and really cause them a lot of physical disability there too. So those are some of the common things, but there's also, irritable bowel syndrome sort of symptoms, and nervousness, anxiety, shortness of breath, a lot of lung issues. I'm on Twitter at Wes Ely MD, just A is at WESELYMD. And a few weeks ago, I put a tweet out about the ongoing lung problems after COVID and the fact that mild COVID oftentimes leads to long COVID. So just the fact that you think that you don't have a problem with long COVID just because you didn't get that sick, untrue. Untrue. So those are some thoughts about what you asked.
Yeah, I had a friend who, got over COVID, pretty quickly, probably, 3-5 days maximum, but he did find that his cardio was, affected for months afterwards, like to a point where, he could certainly still work out, but not, nearly to the exercise capacity that he had before. And again, this was a guy who got over it more and had fairly mild symptoms for 3 days, 5 days maximums. And I understand the logic behind that if I have severe COVID, I'm probably more likely to get long COVID, but unfortunately it just doesn't seem to work out that way. Even if you do get a mild case of COVID where say you recover and you're back to work and back to working out in 3 to 5 days, there is still potential for long-term sequelae. And I think the other part too that makes it a little bit difficult to diagnose, and it's sort of like a compounding problem, is that there does seem to be some type of neurological effect on these people. But in addition to that, some people are just getting depression or anxiety just from loss of job, loss of income, not being able to contact friends and things like that. So it seems like they're getting some things that are affecting their general lifestyle that's certainly causing some depression and some anxiety, but then you have something neurological on top of it, and then you get kind of like both at the same time, and it's very hard to distinguish. But also too, they're both going to present very similar symptoms, and some of those symptoms are going to compound one another. So it's very difficult sometimes to assess someone who does have long-term COVID, particularly if it's with kind of like vague symptoms that are related to mental health, because it's hard to know whether this is sort of like a lifestyle thing. Like, is this a person presenting this way because they lost their job and because some of their relationships aren't as good anymore, or is this something that is affecting the brain from COVID? And I don't know if you had any patients like that you've seen.
I've had quite a few, and I think your description of it is excellent. So I don't have a lot to add to that, but I just want to affirm that what you said makes a ton of sense to me, and I think that I love the fact that you brought that up so that your listeners can be really aware, you know?
Yeah, absolutely. And on that note, unfortunately, we're basically at a time here now. I know that you've mentioned your book a few times, but again, if you can just put out your Twitter handle where people can buy your book. I know that you can probably get it on Amazon, but I'm sure that there's another website where maybe more of the proceeds will go to long COVID patients than to Amazon.
Absolutely. Let me do that. But let me leave you with one paragraph from the book that I think the listeners will resonate with. And it's, you know, during my life as a physician, I had the privilege to care for Maya Angelou, who's a wonderful poet laureate of yes. America. And in response to my love of her and her writing and her teaching, I found her son towards the end of writing the book. And so in meeting him, I wrote this in the book. And there's a quote in here from Maya Angelou that's not present anywhere else on the internet. And I'm really proud of the fact that I'd like to leave your listeners with this quote. So recently, I was fortunate enough to connect with author and poet Guy Johnson, son of Dr. Maya Angelou. Her voice had echoed in my mind over the decades since I cared for her at Wake Forest when she was preparing for her poem On the Pulse of Morning at the inauguration of President Bill Clinton. I was excited to speak to Mr. Johnson. And when asked what it was like to grow up in the shadow of his mother, he responded, I grew up in her light. Sometimes I wasn't worthy of it, but it has always been an experience that expanded me. I sensed this graciousness, this wise humility when we spoke. I told him with a schoolboy's enthusiasm about the way his mother's words had reached me and struck a chord. He told me, and this is the beautiful quote, that she taught him, son, I write from the Black perspective, but I aim for the human heart. And I think if all of us can think about the human heart in the person right in front of us and develop a sense of cultural empathy, that means an awareness of all the things that person brings to the table when I am lucky enough to care for that person, their background, their socioeconomic background, their language, the foods they love, their spiritual background, the things they believe in or don't believe in, and that I can try and meet them where they are and show them the respect and the dignity that they deserve from a healthcare provider, a healer, then we will get closer and closer to one another and not feel so divided in society, but rather on the same page so that we can bring more healing. And I'll close with my working definition of mercy. My working definition of mercy is to dive into the chaos of other people's lives and provide lifting and healing. And what I hope the listener will take away from all this is that our goal here is not just the diving into the chaos of each other's lives, but that we have to find a way to lift and heal. And that is our goal here. And so whatever I can do to help you lift and heal, well, that's my role, because I am here to serve you. And as a servant of you, I have to understand who you are and what matters to you. And that is aiming for the human heart.
Well, that was very, very beautifully said. And I really, really appreciate you saying that. And I think that in a world where there's, quite a bit of division right now, the more we can teach people how to be empathetic and to understand others instead of to judge others will really serve us well in the future. So again, thank you so much for sharing that with us.
You're absolutely welcome. And in the book, you asked where it can be bought. Every deep drawn breath can be bought anywhere books are sold, basically. There's a great audio version of it as well, if you like audible versions, by Grover Gardner, who's a really famous narrator. And I'm just really proud that he was the one who wanted to do this book, because his voice is pretty amazing. So good luck, and thank you so much. And I hope this has been helpful to you all. And please reach out to me on Twitter at Wes Ely MD if I can be of any help.
Okay, well, thank you so much again for coming on. I'm sure if the listeners are going to be, getting at me to have you back on. So thank you so much for coming on. I really enjoyed our conversation today and all the insights that you provided.
Sure, we barely scratched the surface. There'll be a lot of reason to get back on at a later date. So let me know how you are, and have a great day.
Okay, thanks again.
Bye-bye.